Good afternoon.
Hello.
Hello again. I have 10 policies to present this afternoon. Most of them are mostly formatting changes and just word changes. There's not really any big substantial changes to the actual policy. The first policy that I have is RI, non-discrimination in admission and treatment policy. This was really just formatting, changing district to JPS, that type of thing.
Okay. Move approval of the non-discrimination in admission and treatment policy.
Second. Any discussion? All in favor, please say aye.
Aye.
Those opposed, same sign. Okay.
Second policy is patient care, 1100, continuum of care plan policy. This really was just some changes to the procedure, mostly grammatical and clarification, where it was discussing, instead of just case management, referencing more like inpatient case management.
Yeah, I went through those one day, and I didn't really see on any of those policies any major changes.
There's no changes.
Just every now and then they've changed a little bit, so.
Mostly, like I said, grammatical changes. They've added reference, things like that. Do you need to vote on it? or
Motion
anything?
by Ralph,
Second.
discussion. All in favor, please say aye.
Aye.
Those opposed, same sign. Okay, Wanda,
Now we're on number
we have
three.
to change the title on
Just
Change
in
the title.
relation to the motion that's going to be made, if you see fit to accept or approve this, this policy, it has the title on the agenda. The number is correct, PC 2100. It has the title Provision of Care, Treatment, and Services. That's actually the JCO chapter that it comes from. The actual title is correct in the documents that you have available and that you have available to you. The title is Diversion of Patients Policy, so that's when, on the motion, it'll be motion to accept the diversion of patients policy.
And that's policy 2100.
Yes, sir.
Okay.
You okay
It was
with
just
that?
listed incorrectly on the agenda.
Okay.
So, but the policy itself, the policy number is incorrect. This is the diversion of patient care policy. This is, the only changes here was a change in reference, and as far as attachments, to attach the emergency management policy and procedure to this policy.
Approval of the diversion of patient policy. That's the one well, okay.
Yes.
Discussion. All in favor, please say aye.
Aye.
Those opposed, same sign.
The
Baby Moses.
The next policy, number 4, is patient care 2300, acceptance of baby Moses infants. It's basically changing the title and from abandonment of infants at JPS Health Network, and adding verbiage to include the Texas Family Code Title V chapter. They had some specific language in there that we needed to add to this related to specifically if the child had been abused or neglected.
Move approval of acceptance of baby Moses infant policy.
Second. Okay. Discussion. All in favor, please say aye.
Aye.
Those opposed, same sign.
Thank you. The next policy, number 5, is the nursing policy 200, assignment of patient care. In this policy, the only changes were a couple of just minor word changes. I think we added the word "the."
Move approval of the clinical staff safety work Howard policy.
This one is
Oh,
actually.
no, that was
assignment
the
of
I'm
patient
sorry.
care policy.
Oh, I done skipped one of them, okay, sorry.
That's okay.
Oh, okay,
All right.
approval of assignment of the patient care policy.
Thank you.
Second by Ralph. Discussion. All in favor, please say aye. Those
Aye.
opposed, same sign. Next one.
The next one is the clinical staff work safety hours policy. Again, just changing a couple of words in the policy.
Move approval.
Got it? Any discussion? All in favor, please say aye.
Aye.
Those opposed, same sign. All righty.
The next one Policy number 7 is the National Patient Safety Goal 400, handoff communication policy. Again, this is just some change in verbiage regarding our SBAR procedure.
Move approval of the handoff communication policy.
Discussion? All in favor, please say aye.
Aye.
Those opposed, same sign. It passes.
The next policy, policy number 8, is National Patient Safety Goal 600 regarding chain of command policy. Again, it's just changing from adding like JPS Health Network instead of the district, just some verbiage changes.
Okay. You did it? Okay. He
Got it. Nick,
second, all right.
Nick made the motion, Ralph second. Discussion. All in favor, please say aye.
Aye.
Those opposed, same sign. Motion passes.
And then policy number 9, National Patient Safety Goal 1300, critical alarms policy. Again, it's just adding a couple of words, adding the word "the," changing a couple of other words, and clarifying instead of just National Patient Safety Goal 6, adding National Patient Safety Goals 6.0101 to give it better delineation.
Move approval of the critical alarm policy.
And I have my last policy is,
But let us vote. Discussion?
oh, I'm sorry.
All in favor, please say aye.
Aye.
Those opposed, same sign.
Okay.
All right.
And then my final policy is Emergency Management 100, and the only changes on this was some additional references that were added.
Okay, move approval of the emergency management policy.
Discussion? All in favor, please say aye.
Aye.
Those opposed, same sign. Motion passes.
Thank you.
Well
Now
done.
that she's,
Gone?
please, oh, well, you don't mind, you don't have to stay. You don't have to stay. My question is, now that we've approved these particular policies, and, you know, there was just some grammatical changes, wording, do we expect to see those to come back again?
Every 3 years?
Every 3 years? Okay. So you had in one word that now, in 3 years later, you'll put a new word in, is that what?
But even if it doesn't change, it has to come back, right, for us to review to make sure.
That's what I was.
Yeah, okay, that's surprising, but, I mean, not surprising, but I just, one at a time, okay.
And we still have a policy IC1
We got what?
here.
Mm-hmm.
So we're now on to
Yeah, we're gonna,
IC1.
before I forget, out in the hall are the posters from the quality fair. If people didn't get a chance to look at them before, here's another. Because I just stand amazed at how much quality work the folks here put in. I mean, it's unbelievable. All patient care driven, which is what we're about. Okay. Trish.
Before you, I have the Infection Prevention and Control Program Authority and Approval Statement. This is an annual statement that comes before the Quality Board to deem authority to our Infection Prevention and Control Committee to complete the surveillance plan and approve that plan within that committee themselves.
Okay. Where were we? Well, that's the last one, isn't it?
Nope, next to last. So policy IC1.
Right.
Move approval.
Is there a second? Second by DT. Any discussion? All in favor, please say aye.
Aye.
Those opposed, same sign.
Oh, yes, that's-
Okay.
All right. Now we're up to the good stuff.
Yes. So the next item for approval that I have before you is our annual Quality Assessment and Performance Improvement Plan that we refer to as our QAPI plan. This is something that is required through our CMS accreditation cycle. So the plan before you has been updated slightly in some specific areas. Hopefully you've had a chance to review it, but high-level summary of the additions that we've made to this plan include adding high reliability principles and behaviors into the design of our performance improvement and quality program. We've also added additional indicators under the analysis section regarding our serious safety events, and also using quality and safety indicators and external benchmarks for our performance improvement program. And then finally, we've included elements of our clinical risk program related to the Sentinel event alerts as defined through the Joint Commission statements that come out periodically into our safety culture section for that plan. So the rest of the plan remains the same, with the exception of just updating verbiage as it aligns with new elements of performance and conditions of participation under our accreditation bodies.
And good to you. I have a question for you, and I guess this is the time to do it. When I read through the governance part and who sat where's the acclaim group in all this?
Can you tell me what page you're on, sir?
Pardon me?
What page, section are you on?
I'm on page 22. Under
Okay.
scope of the program, it says governance, the district approach to performance improvements formed by the Joint Commission standards, and it lists a number of people. I'm just curious, it was just,
Yeah,
it'll come up again.
right. So acclaim would be integrated into our hospital committees as well as members of the MEC and the PEC. So we're looking at it more as how they've integrated into the network, and we're including their representation on the different improvement committees and also the QAPI committees that are required for reporting elements. We haven't called them out specifically because we see them as already being integrated in some of the other
that's
work.
fine, as long
But we
as they're-
can certainly think more about that if we'd like.
Well, we don't have to do it. Where it became even more sort of glaring for me is there's an organizational chart near the end.
Mhm.
And you don't need to do that now.
But you're right, it should be on there.
Well, when it comes to dealing with quality issues, my understanding is that the physician group is responsible for key performance indicators.
Well, and this isn't this is a committee structure.
No, I understand,
So it's-
committees, but
the claim's not a committee, so you wouldn't list them independently on that,
no,
on that
it
particular
doesn't need to
thing.
be individuals, it's just, where are they? They're not there.
It,
It's something we're gonna get into discussion, I'm
It-
sure, just.
It appears to me that when I read the policy and look at it, most of this is geared toward all of the hospital policies and hospital committees. And acclaim has some additional responsibilities and provide care in the ambulatory setting that don't exactly fit in one of these boxes. And so I think I agree with Chuck on that should be something that is somewhere spelled out, because they really impact the overall care that's being delivered in this system. And it appears to me it's only the hospital when I look at it.
Yeah, I guess my comment there would be that, the Medical Executive Committee and the committees under that have a claim representation and leadership. Our chartered, Quality Safety Governance Committee is also chaired, with medical staff representation, as are most of our QI committees. So they're integrated within the network structure as it's defined, rather than being called out as something that's separate and different.
Okay. I'm gonna try it one more time. Even though they are spelled out and they sit on these committees, when I look at it, it's mainly targeted toward, I know they have a credentialing for the hospital. They have a credentialing over there. So is this credentialing their piece, or is it the hospital's piece?
This credentialing would be the network, the hospital piece.
So I come back to a claim, have separate medical staff committees, and they are looking at things. So somehow that need to feed into the overall. That's what I'm saying.
Understood.
Okay. Is that it for your plan, Trish?
That
That's it.
completes the plan.
DT.
These two nice of both of us saw page 13, item 8, it's arm instead of ham.
Item 8.
I'm sorry, I can't.
It's what I pointed out to you.
Page 13.
That's what it is.
Yeah, the spelling error, we saw that, thank you, we'll correct that.
So let me ask you, Trish, how will you incorporate the changes that we are talking about? I don't mind approving it, but I'd like to have some follow-up to say how it fit in. I think we get caught up in the hospital. We always look at the hospital care, but we are a system, and that's the bit that is not coming together for me.
I don't think it'll be difficult at all. We can take a look at that last section regarding organizational authority and responsibility, change the verbiage there to make sure it's clearly includes a claim. We can also revise what Appendix A looks like. Appendix A is a bit of a living document anyway, as new things come
Okay.
forward throughout the
All
year.
right.
So I don't anticipate that being difficult to include, just so we have it well enunciated in this document.
All right, okay, all right, thank you.
Okay, somebody make a motion to approve it as it is.
Hey, Dan, I'll
DT.
second it.
Dorothy, second. All in favor, please say aye.
All right.
Those opposed, same sign. It passes.
Thank you.
Thanks a lot, Trish. Okay. Is that the end of the, we up to Laura now? We are up to Laura.
They're supposed to be here, and they do it on the other, they come back site.
Patient
But it might not be outside, it might be.
Hello there.
security.
Happy New Year. Hello, everyone. I'm here today to talk about our patient experience structure and the way that we have changed it this year, and then share with you what you can expect for the next meeting as well. So as Bill mentioned this morning, we changed the way that we are tracking our organizational goal, and I wanted to be sure that you were all familiar with and had access to the actual questions that we're asking on the HCAP survey, which is the national survey. It's issued by CMS, and they are listed under the dimensions. So the dark bar that you see for on this particular slide, where it shows care transitions, communications with nurses, communication about medications, discharge information, overall rating of the hospital, communication with doctors, cleanliness and quietness, communication about pain, responsiveness of the hospital staff, and then would recommend the hospital, are the 10 dimensions that we are measuring under our organizational goal that has to do with inpatient. Whereas what you saw in the past was just the overall rating of care and where we ranked percentile-wise across the country. So this is a very different structure. And what I like about this structure and what we're finding from our team members is that they're actually understanding their ownership piece a lot better. And that was the design of this to begin with. So under each of these dimensions, you see different questions. And then as those questions roll up, you'll be able to see how many of those dimensions overall are we moving. Are there any questions on the dimensions or the questions? Okay. On the next, pardon me? We good?
I just asked seeing if anybody had any questions.
Oh, okay. On the next slide, what you'll see are our newly designed dashboards, which this one has to do with our inpatient and HCAPs. On the left-hand corner, you'll see the number of dimensions that currently are meeting goal. And again, as was mentioned this morning in the Finance Committee, this is the average rate of improvement nationally. So what you'll see is the fiscal year end number and then the fiscal year 19 goal, where we are so far for the fiscal year to date number, and then monthly performance. Have we met or not met that goal, and by what number have we met or not met? This is actually what's available to all of our team members now, and so we have begun and completed some of the education on this and continue to do that with our team members throughout JPS as well as our providers.
Good.
Laura?
Yes.
As you look at all of those, the areas that are not met,
Yes.
is there a plan in place that says why we didn't meet it and how we attack why we didn't meet it?
Yes, and actually what I'll bring back to the next quality meeting is the structural plan from the Executive Steering Committee that then breaks out into committees across the network. And those are inclusive of team members as well as our physicians and providers from every single area. So whether it's a claim, sound, physician group from the hospitalist side, IES from the emergency department side, et cetera. So we're including all of those people within the committee structure, and plans and activities are happening in those committees at this point. And I'll bring that structure back so you can actually see it.
Yeah, 'cause it would be
It's
good
new
just-
for this year.
I think it would just help. Sometimes when we don't meet a particular goal,
Yep.
it's not because of bad performance. It's
That's
just
correct.
some extenuating circumstances, some occurred, and it would be good to know
Yep.
what those things are.
Yeah, that's actually a really very important point, because if you'll recall, a few years ago, JPS was recognized as the largest improvement large hospital across the country. And when that happened, we made quite a large jump. We went from below the 50th percentile to right around that top quartile, which we've held. And we have actually improved the number. It's just that the ranking has changed as well. What happened to us at that point is the number of responses that we get that have to do with good performance or great performance increased substantially. And what we find now is our greatest opportunity is in just kind of tweaking and twisting things a little bit to make them slightly better, which then helps us meet and improve the performance of our patients. So it's harder to go from good performance to great performance than it is to go from average performance to great performance. And so that's where we found ourselves the last few years.
Okay.
Any other questions on that? Okay. And then on the outpatient side, if you'll recall, we actually measure 3 different areas. So we measure our primary care, our specialty care, and our women's health clinics. The structure and design of the dashboard is the same, although you'll see all 3 of those mentioned on this particular dashboard. Our target right now is 5. As you saw a bit earlier, we're actually meeting 7 of these dimensions at this point in time. And the questions that are on this survey, this is a different survey, and it is actually issued in real time. And so when a patient leaves our clinics, they receive a survey in the next 24 to 48 hours. It's a similar survey that we started using in the emergency department as well. And on the left-hand side of this particular slide, you will see the questions that are actually asked of our patients. And that goes back to the question that was asked a little earlier today as well. So you can see a large chunk of those are provider-related because that's a really important component of the clinic structure, but then it does also cover the ease of getting appointments and timeliness of seeing the provider as well as overall rating of the facility.
Is this, is the question, the survey asked of the patient prior to leaving, or this mailed to them?
It's actually, we just changed the structure of it. So it is an email that goes out, and Annika, correct me if I'm wrong. So Annika Fisher is you want to come up? Annika Fisher is our executive director of our patient experience program, and she actually manages the survey distribution and the way that that's done. So I don't want to misspeak because this is a brand new way of us surveying. So you want to talk about how it's distributed?
Hello, everyone.
Hey there.
So all of our patients will get an emailed survey if they have an email on file with JPS. If they do not have an email on file to JPS, it's an automated phone call. So rather than the inpatient survey that's actually a live person per CMS regulation, this is just a quick automated phone call, goes through each of the questions, and that's the end of the survey. So it's either an email or automated phone call. We don't send anything via mail. We've kind of transitioned out of that to be a little bit more technology focused for those who like that method, and then for those that prefer the phone, we still have that option. It takes less than 1 minute to take, so it is a lot shorter of a survey than the inpatient survey.
And we've actually received over 11,000 back so far this year, so. I don't know how many.
We have about a 30% response rate, so it's a very significant response rate. Actually, inpatient as well, we have about a 24%, which is higher than the national average.
So when I leave JPS, am I made aware that I'm going to receive that email or phone call?
That depends. That is actually one of the action steps that we have in place right now. Some do talk about it, some do not. And so there's a consistency that we've got to get to in order to make sure that we continue to make that a better rate of improvement as well.
Yeah, because I think that helps if I have some prior knowledge that I'm going to receive it in the next few days or whatever. And I say that because, you know, I've sat here on the board and have heard and discussed about getting those surveys in the mail and then to have my personal self experience that. And I got the, I don't know, I can't think of the name of the company now, but I get the survey. It was 1 million questions. I almost stopped. That's when I was asking if it's quick and to the point. I think if you tell me you're gonna get a 10-question questionnaire, would you fill it out? I think it helps, but I think one of the reasons we don't respond is because they're so long and the questions are so detailed and you gotta think back, you know, so.
Yeah.
For all of our areas that didn't have regulation tied to it, we tried to create a better experience for our
Right.
patients in taking the survey, and that's where we've opted to the less than 1 minute versus the 13-minute survey. So it's a pretty significant difference in that. We do get a pretty high response via email as well. It's just easier for a lot of people that do have email access to respond via that manner.
When you're in the hospital, is that a part of your discharge information that says somebody's gonna call you or you're gonna get an email? I mean, that would be a fine place to list it
Yeah.
because you give it to everyone when they're being dismissed or
Yeah,
or
so,
even from your visits at the clinic.
so the answer is yes. However, does it happen 100% of the time? And that's where I think we've got the question and where we need to get better.
Better,
But I will tell you that all of our patients that are discharged from the hospital have a visit from a care ambassador, and they do talk about it during that discharge piece.
Well, does that happen over the weekend?
It should be happening 7 days a week. They're
Talk to
here
me
7
later.
days a week. I will, and
Yeah,
that's what I'm saying. It's exactly the point, exactly it, Dorothy, because,
But I would think that we have the discharge information. It shouldn't be that hard for them to add something to that would print out kind of on your communication
Oh, on the
that says.
ABS?
Yeah, I mean, they give you something they give you 10 pages, and they give you information about your follow-up, and it could be inserted right there, because folks do read it. And so I would think that might be a place that you want to say, either you're gonna email them or, you know, you might get the email address too.
yeah, you know, I think this goes back to what the whole point of these surveys is, which is consistency in the manner in which we deliver care. And that's where we continue to strive, right? I mean,
Yeah.
our goal and what we work for every day is that regardless of whether you're here on a Monday, on a Thursday, or on a Saturday, it doesn't matter, that your care is the same, and whether, you know, you've got day shift or night shift, it's the same care, same level of care, and that's hard to do.
Yeah.
It's hard to do. I did want to also, any other questions on the survey or anything along those lines? The other thing that I wanted to mention, and you all had asked for, we are still tracking our emergency department, even though we're not showing it on our organizational goals. We use the same survey manner that you just saw with the clinics, and actually the emergency department has improved in all 10 questions over last year. So and continue to make great, and that's inclusive of the urgent care, the CDU, and the emergency room as a itself, so. All right. My pleasure. Anything else?
Anybody else? Any questions?
Okay, thank you all so much.
Very much,
I know.
Professor.
Here, do you want this?
I had a look at the communication with doctors.
Okay. Patient safety and adverse events composite, PSI 90. Tricia.
Okay. So I just have a few slides here to go over our quality goal, which is new to the organization as far as measuring it in that way. It's historically been called PSI 90, but the new way to refer to it is the Patient Safety and Adverse Events Composite. That's quite a mouthful. So PSI 90 is usually the way we refer to this metric. So an overview of what PSI 90 is, it's a composite metric that's been developed by the Agency for Healthcare Research and Quality. We often refer to that agency as AHRQ. The composite measure includes 10 metrics that are considered to be amenable to prevention through system-related structures and processes of care. So really lends itself to a lot of performance improvement work and activities throughout the system. And the PSI 90 composite is also considered to be risk-adjusted to some level based on severity of harm and the volume for which is observed compared to what would be expected for the patient population. So Bill mentioned this earlier, each of the 10 metrics within PSI 90 hold a different weighting. And the weight distribution is listed for you here. You probably recognize some of the conditions that are contained within the composite score, because we've talked about them before, such as pressure ulcers or a fall with a fracture. But some of the other more technical conditions like pneumothorax are, related to, puncturing a lung during a procedure or a line placement. We talk about post-op wound dehiscence, and that really refers to the wound edges separating unintentionally. So there's a mixture of metrics contained within this composite score. Many of them are related to the surgical arena, but it allows us to take a look at processes of care and standardize those across the network, though we're measured as a leading indicator in our surgery population.
Before you go on, if you would, I am fairly significantly red-green colorblind, as is the individual sitting to my left. Could you tell me
What colors are up there?
what is the 30.45?
That would
Which
be
one?
post-op respiratory failure.
Respiratory failure. And how about the 18.39?
That would be perioperative DVT and PE.
Perioperative DVT and what?
PE, pulmonary embolism,
Gotcha. And then what's the 25.52?
postoperative sepsis.
Okay.
What Dr. Weber and I see is a circle.
Continuous circle.
Like a wheel?
Yeah, we see a circle.
Okay,
Okay, thank you.
great.
Question. How do you keep track? Is this something that is tracked within some system concurrently, or is it post or pre or whatever?
Yeah, I would say a little bit of both. So the conditions are gathered through coding, and so we're able to at least sometimes have an idea that a code will be associated with the case, but it's primarily done retrospectively through code assignment after the patient's been discharged.
Okay. Is there any plan to do concurrent? Because when you deal with sepsis and all that stuff.
Yeah, so, and we actually do some concurrent review. So, for example, postoperative sepsis would be related to surgical site infections, right? And so if we're able to identify patients who are having a surgical site infection episode, we would be able to intervene in real time to prevent, further condition decompensation into postoperative sepsis. So there's ways to get into that concurrently. How code assignments happen after discharge sometimes are not easily predicted, but taking conditions that lead one to another are a way to get in front of the condition to be proactive.
Is it helpful to find a way to do it concurrently so that you can have rounding? So that you can take action while they're still in certain area?
Yeah, I think you're speaking to a really kind of being proactive in the way that we monitor our patients. And what we look at is the things that are known to prevent these conditions from occurring in the first place. And those are the leading indicators that we monitor. So, timely antibiotic administration, ambulation, fall precautions, skin integrity assessments. So the behaviors that we desire to prevent the condition from happening are the things that we monitor in real time.
Does that feed back into like an epic or something so that you can have like a cheat sheet or a work plan, or how does that work?
Yeah, it does actually. So a lot of those preventative measures are documented. And so we're able to kind of go in there and take a look to see whether the care is being delivered, and if it's not, do we have an opportunity to question why and follow up in real time. Yeah.
I got lost somewhere, because I thought we were looking at this stuff concurrently. I thought that was one of the things that we had, like on trauma services, the nurses would be looking at every one of these every day. Is that not true, Bill? I did.
My definition of concurrent is much different than leapfrog. These are things that we track routinely.
Right.
It's kind of leading indicators of what a potential leapfrog survey might tell us for a school. Question about.
Are they done concurrently? While the patient's in the hospital, if one of these pops up, is it?
Action plans that are developed around many of these, if not all of these. That's the plan. Because I do know that within the clinic, there are some service lines that have gravitated to these, right, to align themselves with what the organization is doing. We're working on that.
Okay.
So I'm assuming that these are some of the things that you do kind of a little bit post, but more toward evidence-based versus best practice, that we were trying to move toward evidence-based type thing to feed it back up later on as you see things.
Oh, absolutely, absolutely. So the goal is to not have these conditions happen at all, and so monitoring the preventative measures that we know are evidence-based, that prevent these from happening in the first place are what we do every day concurrently. And then we also look at the coding, and look at that as concurrently as possible before it's finalized, to even, determine whether the coding was accurate to the clinical scenario, or whether we had a documentation opportunity to be more clear and accurate in the way we documented the care.
Is this the one that feed right into the IMO online type thing for coding?
I'm sorry.
Feed into the system, IMO online type thing?
Yes,
for
it's all
prospective coding?
online, yes, yeah, electronic. Mhm.
Good. Yes.
Okay. So moving forward in this presentation, this is just a snapshot of what our annual goal statement and our metric statement look like for PSI 90 under the quality pillar. The box on the bottom is, we've looked at this several times, now even today, of what the metric looks like. So we have a baseline of 1.1, a threshold of 1.2, a target of 1, and a stretch of 0.88. And this is that observed over expected ratio is how this is measured. So a 1 would be performing as expected, and so on and so forth. So where we are at year-to-date is 1.3, slightly over our target, which is our expected performance.
And that's for each one of the,
That's for all 10 together.
10 together.
Correct.
all 10 together?
Yeah, so the PSI 90 composite score reflects all 10 of those rolled up into one number.
I think I got it, but I'm not sure that I do. I'll have to get you to help me out coming up with that number.
Sure, yeah, it's a little complex, and on the scorecard that I have next on the agenda, we do kind of spell that out with a little more detail that might be helpful.
Okay.
And we can take that offline, and we can take that offline with any other board member to go in a little more detail as to
Right.
how that comes up to that.
Sure,
Yeah, I had forgotten the charts.
okay.
I'll just have to do some studying. Okay.
This one ties with Bill's
Right.
earlier.
Right, right. So that's completes the PSI 90 overview agenda item, and we can move into the scorecard agenda item if you're ready for that. Okay, all right. So before I talk about the contents within the scorecard, I did want to just take this opportunity to introduce what this new scorecard looks like, because it's a bit refreshed from what we are used to seeing in the past. We've taken an opportunity to redesign our scorecard and align it with the definition of quality as defined by the Institute of Medicine. So we have different sections of our scorecard now for safety and timeliness, effectiveness, efficiency, equitable, and patient-centered. And so that's really how the Institute of Medicine defines what healthcare quality is. And so we've tried to organize our scorecard in that same fashion. Up at the top, we have taken the liberty to go ahead and put our leapfrog safety score at the top, since it's something we look at frequently and just to keep our eyes on it, in addition to our CMS star ratings, which is on our Hospital Compare website. It's public knowledge for anyone who wishes to take a look at that. You'll notice also, as I work through this, what we've done is with each metric on the scorecard, we've listed for you whether it's new, whether it's been carried over from our previous scorecard, or whether it's been just updated to be more current. So the first section is what our PSI 90 composite score looks like. And underneath that are each individual metric and where their score is in relation to the target. And then month over month, and then also year to date. So as mentioned earlier, our PSI 90 is at 1.3. So it's a bit over what our target is. And working down through that, I'll just kind of focus on where our opportunities are. And this will also align with what Mr. Whitman was saying earlier. You know, we have some opportunities in perioperative hemorrhage and hematoma, post-operative respiratory failure, and the DVT and PE post-operatively as well. Those are some of the heaviest weighted metrics within the composite. And I say that because they are so heavily weighted, one event will put us way over our target of where we want to be. So these numbers don't represent many events. They really just represent one, and on occasion two, but it's such a heavily weighted thing, it really will pull us over the line.
And which of these tend to be weighted against each other?
So the weights were, they look like this. So you can see they're about,
So post-op sepsis weighs.
post-op sepsis is 25.52%. Yeah.
For the PSI 09, since it's way up there, what changes needs to be made to bring it back in line?
Yeah, and so PSI 09 is one of the focus areas for us. You know, the number that you see there for December as an example really represents one event. Because it pulls such a heavy weighting in the algorithm that one thing is going to push you over where you want to be. But this particular metric has been included in the orthopedic departmental scorecard as one of their focus areas. So we've really just elevated the attention to this. We're doing case reviews each time we see an event come through. And we're also doing bi-weekly coding and documentation reviews just to make sure that there wasn't an opportunity to put something in the record to better explain the clinical scenario. Because, as we know, surgery is risky by nature, and sometimes risks are inherent, sometimes they're not, and that's where our documentation kind of comes into play.
About acute kidney injury? Is that from a physical, taking out the wrong kidney or stabbing the wrong one, or is that considered as people like in renal failure post-op?
Right, it's
Whereas a kidney-
metabolic in nature, so the kidney injury is really kidney failure postoperatively. So it's not taking out the wrong kidney, but more metabolic balance
Okay.
issues, diabetes, kidney failure, things like that.
Okay.
Yep, and we've had no events for that metric.
Unbelievable. Okay.
Okay. So I'll move forward to the other sections of our scorecard. Next time we meet, we will have the data filled in here. We wanted to take this opportunity just to introduce and socialize what the new scorecard looks like and the components contained within. So the rest of the safety section on our scorecard includes the falls with injury, which is a carryover from what we are used to looking at. We've also like to include a couple new metrics related to harms prevented and lives saved, and these are really complementary metrics as we're looking at PSI 90, so that we can also begin to quantify what are we actually preventing and how does that translate into people and lives. And then also hand hygiene compliance we'd like to include on our safety section. Underneath that, you'll find all of the hospital-acquired infections. And again, we're really used to looking at those surgical site infections because they were part of our reports last year, and we looked at them in counts. What we've done for this year going forward is looking at the standardized infection ratio, so making that a bit more clinically significant and risk-adjusted. And we've taken the liberty to include all of the other hospital-acquired infections that are included in our surveillance program, so we have a complete picture of what's going on in that program.
Okay.
And the last slide here is just what the bottom of the scorecard looks like. So we have one or two metrics here included under timeliness with your left without being seen, which again is a carryover metric. Effectiveness, which is our hospital-wide mortality rate, that is a new metric. Then we have the efficiency section, which we're including our geometric length of stay.
What does that mean, geometric length of stay?
Yeah, so that's actually looking at what's expected for length of stay rather than what the actual length of stay was. Just taking a look at specific attributes for the patient population and what that DRG says the length of stay should be, and we take a look at what the length of stay was compared to that.
Okay.
We've also included the readmission rate under the efficiency section. So a lot of times it's beneficial to look at length of stay and readmission rate together because they influence each other when you work on one. We have an equitable section, and Ms. DeBose, this is back to an earlier conversation you and I had to not lose sight on what this metric looks like and include it in the quality discussion. So that is there. That's the population health organizational goal. And then Ms. Burnside already has reviewed what our service goals look like. We've included that under patient-centered as well. So that's an overview of our patient safety and quality scorecard and what you can expect to see going forward. Any questions? Okay, great.
DT, Dorothy, any
Thank you.
comments?
Nice scorecard.
Very
Okay,
good, thank you.
thank you.
Very ambitious. So now we got the antimicrobial stewardship update.
Good afternoon. Thank you for this wonderful opportunity to highlight our antimicrobial stewardship program here at JPS. I'm James Sanders. I'm one of the clinical pharmacists here at JPS, and I co-chair the stewardship program. And in the second slide or so, I'll introduce a couple of my colleagues that also help with this program here at JPS. So I'll start with why is this important and why has it become a quality initiative here at JPS? As you know, there's a lot of antibiotic use out in the community, and it's unfortunate that if you actually look at the appropriateness of the use of antibiotics, and that's generally what antimicrobial stewardship is looking at, is to make sure we're using these antibiotics appropriately, that upwards of half of the antibiotic use across the inpatient, outpatient setting is inappropriate or unnecessary. So why is this important? Well, it's exposing our patients potentially to adverse drug reactions. It's also increasing the number of bugs that actually don't respond to some of these antibiotics anymore. And another thing is that you may have heard in the news lately is about C. diff or Clostridium difficile infection. The number one risk factor for this is antibiotic exposure. The unfortunate thing is this is a very severe type of infectious diarrhea that kills upwards of 30,000 people in the United States every year. And again, antibiotics being the number one risk factor, if we can limit the inappropriate use, potentially we can limit the number of these infections. The other problem, as the number of bugs out there that don't respond to these agents, it really limits how healthcare providers can treat patients, and we see this at JPS too. There are some institutions that are struggling so mightily out there that they're bugs that don't have any antibiotics that effectively work against them. And of course, this leads to increased mortality. Each year, upwards of 23,000 people die because of resistant infections. And then, of course, you can guess that there's an associated treatment cost from this, just from the agents or because of the morbidity and mortality associated with them. So really what we're looking to do is, there's in the past been this kind of negative connotation that stewardship is there to restrict providers. We're really not there to restrict. We're really trying to help preserve the current antimicrobials we have and protect those that come next. Because it's a unique class of medications that if I give it to one patient, it affects all other patients. You know, if I give you a blood pressure medication, it only affects that one given patient. But an antibiotic given to one of us could affect all of us down the line. So it's very important that we're monitoring for this. And I've kind of listed some of the goals here for stewardship, but I want to emphasize that our main goal is to optimize the clinical outcomes for our patients and protect their safety from some of those items that I mentioned before. So how are we doing that here at JPS? I include this slide just so I could highlight that this is a team effort. It's not just me. I've been lucky enough to have all these people listed here on this slide, and I'll take a minute to introduce Dr. Mandeep Mata, who is one of our physician leads. Couldn't do it without him. That's one of the unique things about JPS. Since I've been here, there's always been physician support for this. I unfortunately was at another institution that didn't have that, and as a pharmacist, it's paramount to have physician support to implement these stewardship programs. And the other thing is you always have to have pharmacy support, so I'd like to introduce Elise Ortega, who's our Associate Director of Clinical Services here, that is always behind me and helping me push forward some of these initiatives. So again, a multidisciplinary approach that has allowed us to have quite a bit of success here at JPS, and this is going on in its current format for at least 6 years now. I've been here, lucky enough to be here for 4 of those. And one of the things that we did early on was try to address key components. This has more recently become a part of the Joint Commission survey. We were lucky enough to have them on site recently, and they were very complimentary of the robust nature of our inpatient program. They were also very impressed that we've started to extend into the ambulatory side, which I'll kind of get to on the last slide. We've implemented some strategies. We've had a lot of support from administration to get data mining resources so we can actually look at our utilization of antibiotics. And we've taken even the next step now, so we are now benchmarking that against institutions of like size and patient makeup across the nation. So we hope to be able to present, you know, similar to infections where you get the SIR, we will have a ratio that we can compare ourselves to other institutions. early numbers look like we're doing relatively well. We've reconfigured some of our antimicrobial testing, so we work very closely with our microbiology department. And kind of the last thing that we've tried to start to focus in on is actually educating patients, because if we're going to affect change in antibiotic utilization, we really have to change the culture. The current culture is patients seek out antibiotics, unfortunately, for all types of infections. So we tried to provide some education for our clinics on, if you get a viral infection, it's perfectly fine for your provider to send you home without an antibiotic. And so we look to do more of that in the future. So I've highlighted some of our top 4 priorities for this year. I'd like to highlight another major issue in the world of antibiotics is that a lot of patients report that they have a beta-lactam allergy or a penicillin allergy. Upwards of 20% say they do, but if you actually test them for true allergies, 80–90% of those don't really have an allergy. Why does that matter? If you have an inappropriate labeled allergy, it leads to different therapeutic alternatives that have decreased efficacy, plus you may have more adverse reactions to that. So we've developed some screening tools here to help clarify our patients' allergies. Plus, we're looking to start doing some skin testing so we can further delabel some of these patients so they get the best available therapy. The other thing, we've compiled a ton of resources and kind of have a repository of those. We really don't have a great place to put them, so we're going to work to have a web page that'll be easily accessible through Epic, so our frontline providers have access to that information 24/7. As I mentioned, we've done a lot with microbiology. We're looking to develop some more rapid diagnostics so we can change the way we treat patients. Currently, sometimes we don't get the best information on bugs and selection of drugs till 3 to 5 days into therapy. You can imagine that's not ideal for somebody that's critically ill. Some of these rapid diagnostics may allow us to know something within 24 hours. So that'll definitely help us improve patient care. And the other thing we want to do is have a good way to monitor inpatient antimicrobial use. We just don't know how to do that really well yet on the outpatient side, so that's one of our priorities for this next year. So that kind of nicely segues into what I want, or what our vision, I guess, is for the future of this program, is to expand into the ambulatory care side. I mentioned 30–50% is inappropriate. Some people estimate that in the outpatient side, it may be 60–80% of the antibiotics are inappropriate. So that's really where we want to go. As I mentioned, Joint Commission is coming up with new regulatory standards. We've reviewed the draft of that document. We either meet or exceed those currently. But really what we want to do is to make sure we can move stewardship from the inpatient all the way to the outpatient across the entire network to ensure we are doing the best by the entire JPS network. And to do that, like I mentioned, we're looking to find better ways to monitor that across the network. And that's going to include looking at our patients to get IV therapy. So I'll end with, our ultimate goal is not to just meet the minimal standards, but really to move JPS to set some of the standards for the antimicrobial stewardship within our community and elsewhere. So I thank you for your time.
What you folks are doing is unbelievably good.
Appreciate that.
Unbelievably. Please, Nick.
So of all the antibiotics prescribed, what % are inpatient, what % are outpatient?
I don't know the exact percent for us, since we're not able to utilize that, but if you look as more globally, the vast majority are outpatient,
Okay,
yeah.
And then are you looking at like carbapenem usage or fluoroquinolone usage in more detail?
Yeah, great question. So I didn't really have a lot of time.
Question again, Nick, what?
What's that? I'm sorry.
What was the question?
The question was, are we
Put your,
looking,
put your mic on.
are we looking closely at carbapenem usage and fluoroquinolone usage?
No, that's a great, and I didn't really have time to highlight that, but one of the things that we looked at early on was fluoroquinolone usage. And the reason that's important is because that set class of antibiotics is associated with a lot of adverse drug reactions, Clostridium difficile, all the things that I mentioned. And we did our best to restrict some of those, or protect, I guess, or to say some of that, and we reduced our utilization by 50% of fluoroquinolones on the inpatient side. Our next goal is to get that into the outpatient side. And on the inpatient side, yes, we do restrict carbapenems too.
When you move over to the outpatient side, are you looking at beyond pharmacology, like drug And with
Looking,
food,
DT looking at what?
topical and all that stuff also
I'm
as well, or
sorry.
just strictly?
Say it
that.
again.
I was wondering when you start rolling it out to the,
DT, I couldn't understand you.
when you start rolling it out to the ambulatory side, I mean, outpatient side, are you looking beyond pharmacology? I mean, like topical and food and all that stuff also as well, or just stick with?
Yeah, I mean, I think
Aye.
generally from, from our JPS focus, we'll more on systemic antibiotics that are administered. But maybe to your point, one of the other huge issues in this whole arena is the utilization of antibiotics within our food supply. Won't be our focus, but yes, it is a focus, I think, globally speaking, is to, get antibiotics out of the food that we eat, because there is that translocation of resistance from animals to humans, unfortunately.
It's still not English to me.
Yeah, when I was practicing, the hardest part was dealing with the residents who wanted to try every new thing that came out. I suspect that has not changed.
Yes, sir, yeah, and education is key, and it's a fine balance between training future practitioners so they have some experience with some of these antibiotics, but not, I guess, too much experience with it. So we do heavily restrict some of the, or protect some of the new antibiotics that are coming out.
But historically, what's happened is the patient expectation in the outpatient setting, they have a cold, they feel bad, they come in, they might have to wait a little bit, and they see the provider, and then all of a sudden we say, well, go to aisle 4 at Walmart and get some saline, some nasal saline, and then they're not happy with that. Well, I want a Z-Pack, or I want something along those lines. And so as providers, we got in the habit of just, writing the prescription, and now we're kind of in a pickle.
Yeah, I would agree, and a lot of that even comes down to patient satisfaction scores, and that's a whole nother can of worms that factors into this decision process.
Yeah, that's good. Appreciate it. Good work.
Thank you all for your time.
On behalf of the execs here, James, thanks the team.
But that's it for open, right?
Yeah, that's it for open.
What'd you say, Dora? What?
Oh, I was just telling him I've been going to the wrong doctor. My doctor won't give me antibiotics when I ask for it. She said, you don't need it. And I'm thinking, I'm gonna change doctors then.
I had not thought about that. Okay, that's it for open session. We need to go into closed session for a very short period of time, so we'll temporarily adjourn this at 15, 20 hours. Take about 5 minutes.
Oh, you're on. All right, you're on.
Back in open session at 16:20 hours. Any other, we didn't have anything to bring in
bring
front
out,
of the
no.
committee, so if everybody's okay, we're adjourned. Thank you.